Adhesive capsulitis. So this is a condition that's not very well understood. For the most part, it's idiopathic, meaning there's no mechanism of injury. There is a secondary adhesive capsulitis, generally either secondary to direct trauma to the shoulder or prolonged immobilization. For the idiopathic type, there's a few things that can predispose people to getting frozen shoulder. One is diabetes, and the other one are thyroid disorders. In terms of the differential, it may resemble other conditions such as what we just spoke about, which is the calcific tendonitis, and other things that can mimic the loss of range of motion would be osteoarthritis, large osteophytes which block the range of motion, as well as loose bodies in the shoulder. Classically, people refer to three phases: a painful, a stiff, and a thawing phase, and they can last from a few months up to a year or more. The classic thing on examination is a loss of external rotation on the affected side. This range of motion, when you try to extend it passively, you can't get past the endpoint, unlike the opposite or contralateral side. In terms of clinically diagnosing this with the use of any kind of additional imaging, you're using that imaging to rule out some of the other conditions we talked about. So ultrasound to take a look for calcifications, x-rays to look for loose bodies or x-rays. In terms of imaging, it's not as useful specifically for adhesive capsulitis. There have been some studies to show that MRI can show a thickening of the coracohumeral ligament. In terms of management, there's a number of options. One is that the patient has the option of doing nothing and advising them on the length and duration of the condition, as well as the fact that they can do things at home as well to manage, such as anti-inflammatories and certain range of motion exercises. However, generally people, given the prognosis of the condition, often want further help. Physiotherapy is a great start in terms of introducing a gentle, pain-free range of motion, as well as some active exercises to get the patient moving the shoulder. And then there's injection options, several options on that front. Some studies show equal efficacy between subacromial and intra-articular injection, although experience would dictate that the intra-articular injection is more effective. There's also a large volume joint injection, which is used to distend the joint. Use a combination of things. There's been evidence with use of just normal saline, 30 to 60 milliliters, to essentially stretch out the joint capsule to give a further range of motion. Some practitioners use a combination of normal saline and local anesthetic, and some include a corticosteroid as well. It's going to be quite a painful procedure for patients and can often be painful for several weeks after the injection. So just to let the patient know if you're going to refer them on for that particular treatment. Another one would be a suprascapular nerve block, which is essentially a local anesthetic and plus or minus a corticosteroid into the suprascapular nerve sheath, which provides pain relief to the shoulder, and that has been shown in some cases to increase range of motion of the shoulder, but also provide pain relief in the painful stage. Finally, if all else fails, a referral to orthopedic surgeon can be considered for manipulation under anesthesia, as well as either arthroscopic or open shoulder surgery to essentially release the anterior capsular tissues to increase the range of motion.
Next, we will talk about subacromial impingement or bursitis. Now, this is a painful structural and mechanical lesion within the subacromial space. And we can classify this into two groups: an extrinsic type, which essentially means that anything that physically narrows the subacromial space, for example, osteophytes, the shape of the acromion, rotator cuff tendinosis, or bursitis, would lead to impingement of the rotator cuff tendons as they pass in the subacromial space. In terms of acromial shape, if you look at the diagram up top, courtesy of the Shoulder Doc website, you can see the type 3 hooked acromion predisposes a bit to impingement in the subacromial space because of that down hooking of the acromion. In terms of other types or causes of impingement, there can be mechanical factors that lead to narrowing of the subacromial space, such as tearing or degeneration of the rotator cuff, which leads to poor centering of the humeral head on the glenoid, which can lead to superior migration of the humeral head, coupled with scapulo-thoracic dyskinesis. All of these factors can lead to bursal irritation and bursitis. Again, the differential here is quite broad and can include any pathology in the shoulder, essentially. So AC joint pathology, rotator cuff pathology, calcific tendinopathy, adhesive capsulitis, glenohumeral arthritis or instability, all potentially differential diagnoses for someone presenting with subacromial impingement or bursitis. On exam, as you may be familiar with, you can kind of do your impingement test, which includes the Hawkins, Neers, Yoakum's or painful arc test, and these may all be positive in a patient with an impingement finding. Pain with overhead activities or arm away from the body positions can also reproduce your pain. AC joint test may also be painful, such as the horizontal adduction or scarf test. Also, push and pressing motions may also reproduce pain in these patients. In terms of investigations, dynamic ultrasound can be quite useful to confirm impingement and also to look at the subacromial bursa for signs of inflammation. An MRI, again, can characterize soft tissue lesions a little bit better, but most times probably not necessary. And then finally, in terms of management for this condition, typically you want to get the patient into physiotherapy to address any mechanical issues such as scapulothoracic dysfunction, rotator cuff, muscle imbalances that can lead to mechanical factors. If there are structural factors involved in the subacromial space, those may be amenable to surgery, such as subacromial decompression or acromioplasty, but essentially those are not typically first-line approaches to treating these. You can certainly consider a subacromial subdeltoid bursal injection with steroid for patients with subacromial bursitis findings. Moving on to the front of the shoulder, we'll talk about biceps tendinopathy and tenosynovitis, which is a condition often associated with other rotator cuff pathology, especially subscapularis tears, which can lead to biceps instability or subluxation. Biceps tendinopathy typically is caused by overuse or repetitive microtrauma, or you can see it in cases of anterior shoulder impingement, which can concomitant poor scapulothoracic mechanics or shoulder instability. Tenosynovitis may occur in conjunction with tendinopathy or in isolation due to an inflammatory response around the tendon, again from trauma or from repetitive load applied to the tendon. The differential for anterior shoulder pain can be labral pathology, or you sometimes may consider other rotator cuff pathology or cervicogenic radiculopathy can also refer to the anterior shoulder. On exam, typically you'll expect to find focal tenderness in the bicipital groove or the musculotendinous junction. You may see pain and weakness with Speed's test or Yergason's test. Most of the diagnosis here is clinical because you can essentially fairly well localize the area of pain on palpation, but you may consider an ultrasound to specifically assess for possible tenosynovitis, which may alter your management plan. Physiotherapy is the main stay of treatment for biceps tendinopathy. Essentially, again, we try that focuses on addressing shoulder mechanics, avoiding or correcting anything that causes an anterior load or impingement on the biceps tendon. So you focus on addressing scapulothoracic mechanics, especially, and again, also addressing any rotator cuff imbalances. Ultrasound-guided biceps tendon sheath steroid injections may be considered for patients with tenosynovitis. You may consider shockwave therapy for calcific tendinopathy. And then finally, refractory cases may require surgical management such as tenodesis or tenotomy.